Good day. This is your glaucoma lecture for third-year medical students. These are the objectives of this lecture. So there are some things that cannot be fully discussed in this video lecture, so you have to read on them by yourselves. But our objectives includes reviewing the physiology of the aqueous humor flow and how it is formed, the mechanisms behind glaucoma, the different types of glaucoma, and the different diagnostic tests, laser procedures, medicines, and surgical procedures for glaucoma. And this is the outline of this lecture. So glaucoma is a neurodegenerative disease. So it is characterized of death of the retinal ganglion cells and the loss of their axons. Now, the retinal nerve fiber layer defects will have subsequent optic nerve cupping, excavation, and other optic nerve changes. There will be an equivalent visual field loss for patients with glaucoma, and they are usually associated with an elevated intraocular pressure. So anatomically, glaucoma could either be open angle or closed angle glaucoma. The risk factors for glaucoma are the following. So increase in intraocular pressure, old age, race, family history, certain medical conditions like hypertension, diabetes, anemia, certain eye conditions like being nearsighted or myopia, or farsighted like hyperopia, having had a previous eye injury or eye surgery, sometimes early estrogen deficiency, and taking steroid medications, especially those taking steroid eye drops for a long period of time. So this is a picture of the normal eye comparing with an eye with glaucoma. So if there is glaucoma and there is increase in intraocular pressure, this increase in ocular pressure will build up and cause damage to your optic nerve. Now, the increase in intraocular pressure could either be due to increased production of your aqueous humor fluid, or there is a problem with the flow of the aqueous humor inside the trabecular mesh. This is a picture of how a patient with glaucoma sees. So, for example, if you are a normal person, then you're able to see the whole picture. All the trees, the sea, the sky, you're able to see everything. With early glaucoma, there's some peripheral changes, or peripheral visual field changes. With advanced glaucoma, so the view or the vision is going to be a little bit smaller, and with extreme glaucoma, it is called tunnel vision. So it's like looking through a telescope. So that's what people with extreme glaucoma sees in the extreme cases. So let's go to the physiology of the aqueous humor. So the aqueous humor is produced in the ciliary body. The outflow goes to the Schlemm's canal through the trabecular meshwork or to the uveoscleral flow. So there is two outflows, either through the Schlemm's canal or through the uveoscleral outflow. The rate of aqueous drainage depends on the contraction of the ciliary muscles. And the major resistance to outflow comes from the juxtaclavicular tissues. So in this picture, you're able to see the flow of aqueous. So your aqueous humor, look at the arrows, the black arrows. So the aqueous humor is produced in your ciliary body. Now, the ciliary body is in the posterior chamber. From the ciliary body, the aqueous, which is fluid, flows outside through the pupil. And then from the pupil, it goes into the anterior chamber where the angle is located. Here in the angles, it will flow through the trabecular meshwork into the Schlemm's canal into the subconjunctival space. So that is the primary aqueous humor flow pathway. The secondary pathway is flowing through the uveosclera. And then it just gets absorbed into the choroid and the other subconjunctival space. But majority of the aqueous humor flow goes into the aqueous humor flow pathway, or the conventional pathway, which is through the trabecular meshwork into the Schlemm's canal. So glaucoma, the main pathophysiology of glaucoma is death of the retinal ganglion cells, or retinal ganglion cells apoptosis. There's also thinning in the inner nuclear and nerve fiber layer of the retina and axonal loss in the optic nerve. It cannot regenerate. That's why when there is an optic nerve damage due to glaucoma, it is irreversible. Now, how do we go about with the clinical assessment of glaucoma? First is we check the intraocular pressure with a procedure called tonometry. The normal range is from 11 to 21 millimeters mercury. The most widely used equipment is the Goldmann applanation tonometer, and it is attached to a slit lamp. The corneal thickness influences the accuracy of the intraocular pressure. And there is diurnal variation of intraocular pressure, meaning that the intraocular pressure may change when you wake up in the morning, during lunchtime, in the afternoon, or before going to bed. It is usually highest when you wake up in the morning. So this is a Goldmann applanation tonometer. The one with the bright blue light is the Goldmann applanation tonometer. It is again attached to the slit lamp. Now, another procedure that is done to be able to determine if the angles are open or closed is called gonioscopy. When the angle is open, the ophthalmologist is able to visualize the trabecular meshwork, the scleral spur, and the iris processes. When it is narrow, then only a small portion of the trabecular meshwork is seen. And when it is closed, you're unable to see the trabecular meshwork and the Schwalbe's line. This is a picture of what an ophthalmologist sees during gonioscopy. So these are the parts of the angles of the eye. We have the Schwalbe's line, as seen in the blue arrow, trabecular meshwork, the pigmented, dark brown pigmented band. We have the scleral spur, which is a white band, and the ciliary body band, which is the grayish band pointed in the blue arrow. So again, this is what is seen in the angles of a normal eye or a patient with an open angle. So another procedure is ophthalmoscopy. So during this time, the optic disc is assessed. We have to take note if the optic disc is glaucomatous in appearance, meaning that it could be an enlarged disc with an enlarged cup-to-disc ratio. There is thinning in the neuroretinal rim, or there is atrophy that is seen. There is disc hemorrhage that is seen. If there is cupping of the optic nerve. The normal cup-to-disc ratio is 0.3 to 0.5. This is a picture comparing the optic nerve between a normal individual and a patient with glaucoma. Now, with a normal individual, you can see that there is a yellow-orange disc with distinct disc borders, cup-to-disc ratio of 0.3. There is no rim thinning. There is no peripapillary atrophy or that whitish kind of cup around the optic nerve. You do not see it. There is no disc hemorrhage. Now let's go and focus on the optic nerve in the eye with glaucoma. There is an enlarged disc again. So we describe it as about pale yellow disc with an enlarged cup-to-disc ratio of about 0.9. There is neuroretinal rim thinning superiorly and inferiorly. There is bending of the vessels. There is visibility of the peripapillary atrophy. There are no obvious disc hemorrhages seen. So please remember this picture because it is very important to know what an glaucomatous optic nerve looks like and what a normal optic nerve looks like. Another procedure used in the determination of glaucoma is visual field examination. It can also be done using the confrontation test, but usually in glaucoma, the machine limiter. Central 30-degree yards nasally until it becomes severe and becomes tunneling vision. Let's go to the types of glaucoma. We have primary glaucoma, congenital, secondary, and absolute. Absolute glaucoma is the end result of any glaucoma that is blind and often painful. The most common type is primary glaucoma. So the chief pathologic feature for primary open-angle glaucoma is the degeneration of the trabecular meshwork. So if you remember, the flow of the aqueous or the primary flow of the aqueous is going through the trabecular meshwork and then into the Schlemm's canal. So if there is a problem in the trabecular meshwork, which is like a sieve or a strainer that strains the fluid, then there will be reduction in the aqueous drainage. Now, this will result in an increase in the intraocular pressure and will result to glaucomatous optic discs, visual field changes, increased intraocular pressure, and an open anterior chamber angle. So again, it says primary open angle. So the angle should be open in this type of glaucoma. At the start, it could be asymptomatic or painless, but it is progressive and sometimes becomes bilateral if the vision loss is not treated. But if detected early through proper glaucoma screening, then it has good prognosis as you are able to halt the vision loss or the blindness. There's also a condition called normal or low tension glaucoma. It has the same pathologic features of a primary open angle glaucoma, except the intraocular pressure is not that high. It's usually below 21 millimeters mercury. This is due to the abnormal sensitivity of the optic nerve to the intraocular pressure. It's associated with disc hemorrhages, and 60% have progressive visual field losses. The ocular hypertension is when there is an increased intraocular pressure with normal optic nerve findings and normal visual field findings. This is also known as glaucoma suspect. So anything that might warrant an investigation for a possible glaucoma is labeled as glaucoma suspect. So it can either be an increased cup-to-disc ratio in your optic nerve head without an increase in the ocular pressure. It's also labeled as a glaucoma suspect. Risk factors for ocular hypertension is increasing intraocular pressure, increasing age, greater cupping, family history of glaucoma, and other systemic illnesses like diabetes and hypertension. It is recommended to monitor these patients once or twice a year. Now let's go to the other type, which is primary angle closure glaucoma. It is actually the most common type of glaucoma seen in the Philippines or in Asia. There is angle closure, which results in optic nerve damage and visual field loss. The aqueous flow obstruction by the trabecular meshwork is due to occlusion by the peripheral iris that can cause a pupillary block. So, the fluid or the aqueous fluid from the posterior chamber cannot go outside into the anterior chamber because the pupil is blocked. So that is primary angle closure glaucoma. Or it can still go out of the pupil because there's no pupillary block, but your trabecular meshwork is blocked by your iris and resulting to a closed angle. Then this condition is again angle closure glaucoma. Risk factors are increasing in age, females because we have smaller eyeballs, family history, Asian descent or Southeast Asian descents, Chinese or Inuits because of a smaller anatomical eyeball. So for acute angle closure, it is an ophthalmic emergency. The patient will complain of excruciating eye pain, will see halos or rainbows, they will be nauseated, they might vomit, they might have severe headache, there is eye redness and blurring of vision. When you look at it, the cornea is steamy or hazy. There is iris bombay. There could be iris atrophy also, and this or hemorrhages. So the treatment here is to bring the patient to the emergency room to first lower the intraocular pressure medically. Then the definitive treatment is to do laser peripheral iridotomy, meaning through laser you create a small hole in the iris to allow the aqueous fluid to pass through. This is done by an ophthalmologist. Once this case is detected, an immediate referral to an ophthalmologist is needed. There's also chronic angle closure glaucoma. There's a gradual rise in the intraocular pressure, so the patients may not complain of the severe headache, eye pain compared to the acute primary angle closure glaucoma, but they may have occasional headaches and subacute attacks. The treatment is first with laser peripheral iridotomy and then controlled with medical treatment. But sometimes, if it doesn't improve with medicines and lasers, the patient may need surgery. Again, this should be referred right away to an ophthalmologist. Plateau iris, when there's normal central anterior chamber depth and narrow anterior chamber angle. This is due to the anterior position of the ciliary processes. So the iris actually will bunch up. The peripheral iris will bunch up and then they will cause angle crowding and will cause blockage to your trabecular meshwork. So the treatment is laser procedure called laser iridoplasty or a long-term myotic treatment. Let's go to congenital glaucoma. It's a primary congenital glaucoma. Could be due to anterior chamber angle anomalies only, or could be due to anterior segment developmental anomalies. So meaning there are other problems like problems in your iris, in your cornea, with the lens. So there are also other ocular and extraocular abnormalities. Examples of anterior segment developmental abnormalities are Axenfeld syndrome, Reiger syndrome, and Peters anomaly. An iridia or a vestigial iris can also cause glaucoma because the iris stump might block the trabecular meshwork. Now let's go to secondary glaucoma. It could be pigmentary glaucoma, pseudoexfoliation glaucoma, or secondary glaucoma due to lens dislocation. Secondary glaucoma is usually seen in myopic patients, and there are several pigments that are released during exercise or high-stress activities, which will then block your trabecular meshwork and cause an increase in the intraocular pressure. While pseudoexfoliation glaucoma, there will be fine white fibrillary deposition on the anterior lens surface that will block the trabecular meshwork and cause increase in intraocular pressure. It is also commonly associated with very weak lens zonules, which will make cataract surgery difficult in these cases. Now, glaucoma secondary to lens dislocation may be from trauma or a congenital condition called Marfan's syndrome. So these are examples or photos of the secondary glaucoma. The picture on the right, where you can see an iris with a brownish pigment seen in the photo, is the pigmentary glaucoma. The picture below it, where the pupil is dilated and you see that whitish circular halo on the anterior capsule, is a photo of a pseudo-exfoliation glaucoma. And the picture on the left, where there is a lens that is dislocated, is Marfan's or lens dislocation. Other types of secondary glaucoma is lens intumescence, or the lens is very mature that it takes up fluid during cataract change, and this lens will then block your pupil and cause a pupillary block, which will result to angle closure. There's also phacolytic glaucoma, which is a open type glaucoma, also due to advanced cataracts. So when the cataract becomes very advanced, then the anterior lens capsule becomes leaky and lens material will then seep out of it and go into your trabecular meshwork. It will cause phacolytic glaucoma. There's also glaucoma secondary to uveitis or inflammation, which will block your trabecular meshwork. Glaucoma secondary to tumors like uveal tract melanomas, which will physically block your trabecular meshwork. So in this picture, we have a picture here on the left where there is pigments seen on the corneal endothelium. This is usually seen in patients with phacolytic glaucoma or anaphylactic glaucoma, where the lens capsule or inflammation will go into the trabecular meshwork and cause trabeculitis and increase in intraocular pressure. Now, the picture with the hypermature cataract with a dilated pupil is a picture of an intumescent lens that can cause pupillary block and angle closure glaucoma. Now, the other picture with a mass seen in the iris is a melanoma that will block your trabecular meshwork. Other types of secondary glaucoma is secondary glaucoma due to trauma. So it could be due to traumatic hyphema, increase in inflammation, or lens dislocation. Neovascular glaucoma, which is a very severe type of glaucoma and difficult to treat, it's usually due to diabetes and hypertension and central retinal vein occlusion. Steroid-induced glaucoma simulates primary open-angle glaucoma. Any history of prolonged steroid use, especially topical eye drops, can cause steroid-induced glaucoma. But there are also instances that oral prednisone or oral steroids can cause this condition. This picture on the left where there is blood vessels seen on the iris or neovascularization is called or is seen in neovascular glaucoma. Now the picture where there is here at the right top portion where there is blood in the eye is called the traumatic hyphema, which will then cause secondary glaucoma. It might be due to trauma. Now, the picture below, where there is a cataract, there's eye redness, possibly is due to an steroid-induced cataract, and at the same time that there is increased intraocular pressure, which will cause steroid-induced glaucoma. So taking steroids will really have a lot of ocular complications, so we really have to watch out for them, especially in patients with prolonged steroid use. Now let's go to the treatment modalities of glaucoma. This table will show you the medical or the medicines needed in the treatment of glaucoma. Memorize the classes: beta blockers, alpha-2 adrenergic, alpha-2 adrenergic agonists, carbonic anhydrase inhibitors, both the topical and the systemic types. Memorize the mechanism of action, the side effects. So it is very important to take note of the side effects. For example, if you have a patient with bronchial asthma, then it is contraindicated for them to be given beta blockers. If you have a patient who have several allergic reactions to in the eyes following taking glaucoma medications, then most probably it can be due to alpha-2 adrenergic agonists or carbonic anhydrase inhibitors. If your patient needs to take systemic carbonic anhydrase inhibitor like acetazolamide, it is important to ask for history of diabetes, history of chronic kidney disease, as there are also side effects in terms of the renal function of these patients, especially in those taking acetazolamide. So please memorize this table. The other types, this is also part of the medical treatment, are prostaglandin analog, which is actually the most potent medication for open-angle glaucoma. We also have the parasympathomimic agents like pilocarpine and carbachol, hyperosmotic agents like glycerine, glycerol, or mannitol, and mydriatic agents like atropine. Again, please memorize this table. Now let's go to the surgical and laser procedure that is performed in glaucoma patients. For patients with acute angle closure glaucoma that need an alternative pathway for fluid or aqueous fluid to flow, the treatment of choice is laser peripheral iridotomy. So a laser beam is directed towards the iris to create a small hole where the fluid can pass through. Now, if the laser beam cannot pass through the iris due to very severe corneal edema, severe or very high intraocular pressure, then the patient might have to undergo a surgical peripheral iridotomy. It has the same mechanism for a laser peripheral iridotomy, except it has to be done surgically. Now, for patients with plateau iris, then we go and do the argon laser peripheral iridoplasty. So we actually fix the iris and pull it away from the trabecular meshwork. Now, for patients that will need surgery, glaucoma surgical procedure is called trabeculectomy. It allows direct communication of the anterior chamber to the subconjunctival and orbital tissues. it is the glaucoma procedure of choice at this time for patients with glaucoma refractory to medicines or laser procedure. Okay, so that is the lecture on glaucoma. The next half of this glaucoma lecture for this evening is going to be on visual fields. Okay, so let me just prepare for that. A glaucomatous optic nerve. Okay. Is there like something that is shared now?
Yes, love.
Okay. Good afternoon. This is the visual field testing and visual field defect lecture for third year medical students. Visual field testing or perimetry is an important diagnostic tool used in glaucoma to monitor the progression, and also it is useful in assessing the optic nerve damage. It plays a critical role in monitoring the disease's progression. A glaucomatous optic nerve damage can produce characteristic changes in visual field defects. The visual field changes seen in glaucoma reflect the retinal and the optic nerve anatomy. The retinal nerve fiber radiates from the optic nerve head and are distributed in an arcuate manner around the foveal region. Glaucomatous damage at the optic nerve head produces visual field defects in the region of the affected nerve fiber. The location, distribution, size, and shape of the resulting visual field defect is called a scotoma. This is the Jerome's area. It is the most common location of a glaucomatous field defect. It usually occurs in an arcuate area. It includes the portion of that arcuate region and extends from the blind spot to the median raphe, where it extends 10 to 20 degrees nasally from fixation. This is the beginning of an arcuate scotoma. An arcuate scotoma often begins as a single area of relative loss which becomes larger, deeper, and multifocal. A full arcuate scotoma arises from the blind spot and ends at the nasal raphe. It becomes wider and closer to the fixation on the nasal side. A paracentral scotoma is a discrete area of absolute or relative visual field loss within the 10 degrees of fixation. The scotoma can be single or multiple and can occur as an isolated finding or can be associated with other visual field defects. This is a nasal step. It is a depression in the superior and inferior nasal field near the horizontal raphe. It can occur as an isolated finding in early glaucoma or can be associated with a paracentral or arcuate scotoma. A temporal defect is a wedge-shaped defect extending from the periphery towards the central field of vision. These defects are produced by damage to the nasal neuroretinal rim. The temporal defects are usually found as a late manifestation of glaucomatous visual field loss. This is how a perimetry is done. One eye is usually covered while the other eye is performing the perimetry test. This is an example of an automated visual field machine called the octopus perimeter. This is another perimetry machine called the Humphrey visual field. There are just brands of visual field tests. So let's go to the perimetric terms. We have absolute visual field defect, which means there is no stimulus perceived in the affected area. There's also a relative visual field defect, with bigger and brighter stimuli may be perceived in the affected field, but smaller and dimmer targets are not seen. These are the different terms describing the visual field defects. We have a scotoma. So a scotoma is an area of depressed visual function surrounded by normal visual function. It can either be central, ficocentral, paracentral, pericentral, arcuate, altitudinal, quadrantanopsia, or hemianoptic. This is descriptions of bilateral visual field defects with respect to spatial localization and extent. So when we say homonymous, it means it's on the same side of the visual space affected. Bitemporal, meaning it's opposite temporal sides of the visual field space affected. Complete means that it is the complete field affected. Incomplete is a portion of the field is paired. And congruous means that there is a tendency for the homonymous field defect to be symmetrical. So visual field testing is also done in neuroophthalmology. So there is detection of visual field defects, and it helps localize the lesion along the area of the visual pathway. This is the visual pathway. So it extends from the frontal lobe to the brain up to the occipital lobe of the brain. So we have the nasal retina, temporal retina, we have the optic nerve, and there are two optic nerves which meet at the optic chiasm, and it crosses of that area and becomes the optic tract. There's the Mayer's loop, and there is a lateral geniculate nucleus. And you have now the optic striations that is located in the parietal lobe. So in relation to the visual pathway, there are associated visual field defects. Number one is if there is a lesion in your optic nerve, then there is an absolute defect in your right eye. Number two is if there is a lesion in your optic nerve, but very close to the optic chiasm, so there is a complete defect in your right eye with some defects already on the left eye. Once there is a lesion in the optic chiasm, like a tumor, then it can cause a bitemporal visual field defect. In number four, when there is a lesion in the optic tract, the visual field defect is on the opposite side of the optic tract. For in this picture, number four, there is a lesion in the optic tract on the right side, so you have a left homonymous hemianopsia. And number five, if there are lesions in your Mayer's loop, then you will have temporal defects, but also with the hemianopsia, the same homonymous hemianopsia. Number six is also similar to an optic tract lesion or the optic striates. Number eight is when there is macular sparing. But again, what you have to take note is that once it already crossed the optic chiasm, the visual field defect usually happens on the opposite side of the nerve that is affected. But before it crosses the chiasm, it is still on the ipsilateral side. So this is an example. This 15-year-old patient presented with primary amenorrhea, 2-year history of galactorrhea. She had no visual complaints. Visual acuity was 20/15 bilaterally, but her visual field demonstrated a superior bitemporal field defect, shown in the visual field printout. Her CT scan demonstrates an intracellular mass, so meaning it is hinging on the optic chiasm. Her prolactin was 37 nanograms per cent following treatment with bromocriptine serial MRI scans document shrinkage of the pituitary macroadenoma. Follow-up visual field demonstrate gradual progressive improvement in the bitemporal defect. Another example is a 48-year-old man presented with a 1-year history of difficult reading because of the endings of words would disappear. Visual acuity was 20/20 afferent pupillary defect. So meaning there is a positive RAPD. His visual field demonstrates an almost complete right homonymous hemianopsia, and repeat testing with a V-size test object showed an incongruous relative superior homonymous defect. The MRI shows a multilobar lesion compressing the left optic tract. He subsequently underwent resection for craniopharyngioma. So there is a lesion in the left optic tract which resulted in a right homonymous hemianopia. Another example is a 23-year-old man who complained of blurring of vision to the right side and intermittent but continuous flashing of lights to the right. VA is 2015 bilaterally. Visual field demonstrates a right inferior congruous homonymous hemianopsia with sparing of the macula. His CT scan revealed high-density lesion in the left occipital lobe, which on angiogram proved to be an AV malformation. So now what we can see is a right inferior congruous homonymous hemianopsia with macular sparing. So which means that the lesion is near the occipital lobe. Another example is an 18-year-old woman with an 8-day history of sharp left-sided headaches. VA was 2020 bilaterally. She was noted to be losing letters to the right and bilateral 10-2 programs demonstrated a tiny primary homonymous scotoma just below and to the right of fixation in both eyes. Her angiogram revealed an AV malformation involving the occipital tip. So those were example cases of lesions in the brain which affects the optic nerve tract or the visual field pathway with an equivalent visual field defect. So what's important to note? So the main difference of a visual field defect in glaucoma versus neuro-ophthalmology is that in glaucoma, the visual field defect usually affects the horizontal part of the visual field. So it's either superior field defect or inferior field defect. But if it's a neuro-ophthalmology problem, it usually respects the vertical midline of the visual field. So it's either a bitemporal hemianopsia or it's a homonymous hemianopsia. So it usually has a vertical visual field defect. So again, what's important is when you study the visual pathway is that once the optic nerve already crosses the optic chiasm, then the visual field defect is on the contralateral side of the lesion. But prior to crossing the optic nerve chiasm, the visual field defect is still on the ipsilateral side. And for glaucoma patients, visual field testing is very important in monitoring the progression of the optic nerve damage. It is a very important tool in determining the severity of the glaucoma disease. Thank you for listening and good afternoon.
Okay, so are there any questions regarding the lectures?
Pwede mag-ask, Doc?
Yes.
Ay, kuan, Doc, like, sa first na lecture kayo, naka-mention ka about sa katong aniridia, katong absence na gud sa mga iris, Doc, but like, sa Cebu, Doc, kay naabay ka ng available na for kuan, Doc, kanang procedure like implants ba ron or any na procedures that would correct or address that condition, Doc?
Aniridia, you mean? Or
Yes,
the
Doc.
glaucoma
An-
of the aniridia?
ang aniridia, Doc, kay ng aniridia kay could ang usa sa complication kay glaucoma, pero sa aniridia itself, Doc, ba?
Oh, for the aniridia itself, not really. Maybe just using cosmetic contact lens is something that is the easiest thing to do. For the visually aesthetic, for visually aesthetic purposes.
So more on cosmetics na lang gid siya, Doc.
Yes, because the aniridia is a genetic condition. So there is nothing that can make the iris grow because it's genetic. So for cosmesis, it's going to be a cosmetic contact lens. But for glaucoma is medical and surgical if medicines will not work.
Take it up.
Okay.
Doc, may I ask something, Doc, about surgical and laser camera? Wala ko kapa sa video, Doc. But I will just mention it, Doc. Di ba, Doc, if ang laser peripheral iridotomy, if it cannot pass, then we proceed to the surgical, which is your surgical peripheral iridotomy. Then this is same with LPI, except that it is surgical. Ang wala na ko na kuha nga info, Doc. When do we decide to do the argon laser, Doc?
Okay. So usually the first choice is really the laser iridotomy using a YAG laser. And if the laser iridotomy is not patent or does not lower the intraocular pressure enough, then we can go ahead and proceed with the argon laser peripheral iridoplasty, where now we are actually fixing the iris. So that is the main thing for that. But there is a condition called the plateau iris, where the iris really is the main reason for the angle closure. Then there will be times when argon laser peripheral iridoplasty is the first choice. So it's going to be first choice only if the condition is called plateau iris. But if it's the acute angle closure, the first thing to do is the laser iridotomy.
Clear,
Okay.
Doc. Thank you, Doc.
Any other question?
Doc, ang sa kuan ba, iridoplasty pod ba, applicable pod ba sa mga kanang elderly patients, Doc?
Yes. Yes. Regardless of age, as long as they're able to stay still in the slit lamp, the laser machine. So, but see, glaucoma is really going to be more common in the elderly population, especially the acute angle closure. So, it is also applicable in old age or elderly patients.
Thank you, Doc.
Okay. No more questions?
I think no more na, Doc.
Okay, so just to summarize, the things that you have to take note when you are studying for glaucoma is first, the disease actually involves the optic nerve. So you have to study about the optic nerve. Second, that glaucoma is irreversible. And then there are two types. You study both types, the open angle and the closed angle glaucoma. For medical students, what is important is really the medical management. So do not focus yourselves too much on the lasers and the surgeries. You should know that laser procedures and surgical procedures is indicated for glaucoma. But when you graduate, when you become a medical doctor, what you have to know is the medicines. Okay? And also the signs and symptoms of acute angle closure glaucoma. Because there are times when this will be mistaken as increase in blood pressure, early stroke, severe migraine. And if you see these patients in the emergency room and you do not look at the eyes, you do not take note that the eyes are already red, there's blurring of vision, then you will miss the diagnosis. Okay? So those are the important things you have to take note when you study about glaucoma. So this is the end of the glaucoma lecture. So that's it. If there are no questions, then that's the end of tonight's lectures.
Thank you, Doc.
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 Bye.
Thank you, Doc.
Doc.
Thank you, Doc.